Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features content from an educational symposium titled Easy as 1, 2, 3, Simplifying RSV Vaccination for Older Adults, featuring Dr. Angela Branche. In this episode, she reviews RSV disease burden, symptoms and complications of RSV infection, and discusses risk factors for severe RSV disease. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started.
Hey, hello everyone. My name is Angela Branche. I'm an infectious disease physician from the University of Rochester, and I spend part of my time in practice and part of my time studying the burden of diseases like RSV in adult populations, as well as helping to develop vaccines and treatments to combat some of these. So, as many of you are aware, RSV is a winter seasonal virus. It circulates around the same time as influenza, usually in the fall through the early spring. Depending on where you are, the start of your epidemic could be a little bit different. It could be any time from late October to maybe early December, which is when we start to see it in the Northwest. This is some data from the CDC's network, which was actually designed to look at influenza epidemics and rates in adult populations, but they also have done some surveillance work trying to understand the burden of RSV disease. Now, RSV is harder to find because it's not as routinely tested, but in this study of about 10,000 persons from various parts of the United States, they were routinely testing for both influenza and RSV. Influenza and RSV seasons do overlap quite a bit, and it does span sort of what we think of as our typical Northern Hemisphere winter. 6% of adults hospitalized with acute respiratory illnesses is being caused by RSV, which can look like much lower than influenza rates, which sometimes can be as high as 20%. But looking at data like this doesn't really help you understand why RSV is important, because influenza is an important disease in people of all ages. And RSV, when you're really talking about the disease burden and its impact, you really want to think about older adults. So in adults aged 65 years and older, the annual attack rates for RSV is in the community setting. If they live in the community setting, any year it's anywhere between 2 and 10%. So just think about that. 10% of all respiratory illnesses that they'll be coming to your offices about might be RSV, and that's just probably an underestimate because we don't always test for RSV. In congregate settings, it's typically between 5 and 10%. Even though you might see more RSV illnesses in children every year, all of the mortality is really on the older adult side. And altogether, we think there are about 1.4 million outpatient visits due to RSV in older adults in the U.S. alone, about 160,000 hospitalizations yearly, and anywhere between 10 and 12,000 deaths a year in older adult populations in the United States due to RSV. And again, I want to stress that this disease burden and what we understand about the disease burden is probably very underestimated due to the fact that we haven't historically routinely tested for RSV, and it is expected to increase because we do have an aging population. So many of you are aware of the clinical signs and symptoms associated with RSV. On average, adults seek medical attention 5 to 6 days into their illness because initially it's a cold, right? You might have some rhinorrhea, some nasal congestion, maybe a slight cough, maybe a headache, some malaise. But in certain adult populations, and there are specific risk factors associated with this, RSV can spread to the lower respiratory tract, resulting in pneumonia, bronchitis, as well as exacerbations of underlying cardiac and pulmonary conditions like asthma, COPD, and congestive heart failure. And that's when they're likely to present to your offices, to urgent care, and to the emergency rooms. One of the risk factors that is very well defined and well understood is age. Older age has been known for many years to be a key risk factor for significant RSV disease, leading to hospitalization, morbidity, and mortality. And this is some data from the CDC's RSV net, which really captures this very well. What I want to point out to you with this data is when you look at RSV-associated hospitalizations per 100,000 persons by age group, so looking at younger adults 18 to 49, adults in in their 50s, their 60s, their 70s, or older than their 70s. What you're seeing is that when you look at that over 65 group, with each decade of life that you increase, you're actually doubling the incidence. And so age is one of the best understood risk factors for significant RSV disease leading to hospitalization and morbidity and mortality. We also know that it's an important cause of cardiorespiratory hospitalizations in those living in long-term care facilities, many of them of which are your patients. And so I like to put this in perspective of something we do know pretty well, which is influenza. And when you consider the burden of hospitalizations related to RSV versus influenza in adults living in these long-term care facilities, and this is pretty similar when you think about comparing influenza and RSV. Increasing age also increases the susceptibility to mortality due to RSV-associated pneumonia. So not only are they more likely to become infected, not only are they more likely to become hospitalized as they age, but then there's mortality associated with that. As you increase in age from adults that are middle age, 50 to 64, to older adults, 65 to 79, to adults 80 years and older, then the estimated associated RSV community-acquired pneumonia, the number of cases per 10,000 persons does increase from 1 to 2.5 to 4. But then if you look at mortality in months after admission for RSV-associated hospitalization, there is a significant decline in the percentage of adults that are alive going out to 12 months in those 75 years and older. In general, about 50% of these older adults who are hospitalized with RSV will have radiologically confirmed pneumonia, and about 20% of them will require mechanical ventilation. And this is one of my favorite recent studies that was published, also from the CDC network, the RSV IV network, that again puts the RSV in context of something that we're all super familiar with, the recent COVID-19 pandemic, and compares outcomes of adults hospitalized with RSV to those hospitalized with COVID, and then adults hospitalized with RSV to those hospitalized with influenza. And it looks at what happens to these patients. What kind of outcomes can you expect? The need for oxygen when they weren't previously on oxygen, the need for high flow oxygen or non-invasive ventilation, the need for ICU care, the need for mechanical ventilation, or resulting in mortality. And you're seeing RSV compared against COVID-19, and then you're seeing RSV compared against influenza. And what you see is that no matter how you measure severity, even though you'll see more influenza and more COVID-19 cases in your hospital, if someone has RSV and they're hospitalized and then they're in this older adult age groups, the outcome is almost always going to be worse by any one of these measures. There are other things that increase risk for RSV hospitalizations, not just age. And so I think one of the things we'd like to know as researchers and as practitioners is how these things stack on top of each other. And that's an area of active research that I think we still need to learn better. But there are certain comorbid conditions that we do know increase the risk for RSV hospitalizations, irrespective of age. Things like COPD and heart failure, things like hematologic malignancies, the presence or having had a stroke, and chronic kidney disease have all been shown to have an increased odds of predicting hospitalizations. And that can be anywhere from 2 to 4 times increase if you have the presence of one of these underlying conditions. We did a study in Rochester, New York, and in New York City a few years ago. It was a population-based incidence study where we enrolled everyone hospitalized with an acute respiratory illness into our study and tested at least 93% of them for RSV to try to understand both the population-based incidence, but what underlying conditions were sort of predisposing people for being hospitalized. So this is data from our study which compares the population-based incidence of the presence or the absence of these conditions and whether or not they sort of increase your risk of being hospitalized if you become infected with RSV. Without going into too many details, what I wanted to point out to you with this particular figure is where heart failure lands, because it's not one that we always typically associate with as being a really important risk factor for severe RSV disease, but it may be actually quite significant as things like COPD. Other things that also may play an important role is the presence of diabetes, particularly poorly controlled diabetes, and as well as the presence of coronary disease. And there's numerous studies that have shown that things like coronary disease, if they are pre-existing in your patient who then goes on to have an RSV infection, there can actually be further sequelae, meaning they can have acute MIs after their RSV infections and be hospitalized with outcomes related to the existence of coronary disease before their RSV infection. The last thing I want to show when thinking about comorbid conditions is that, we always put comorbid conditions and age together when we're studying sort of risk factors for RSV disease. But one of the things we wanted to look like in our population-based incidence study is, well, what about younger adults who have these conditions? Is it just age and frailty that are predisposing people to being hospitalized with RSV? Or if you have chronic kidney disease and you're only 40 years old, is that in itself an independent risk factor? And so this sort of gets at that. This looks at different age groups. It looks at all the conditions we looked at in our study, and it looks at what exactly is happening in different age groups in these particular conditions. There's a couple of things I wanted to show you. For heart failure, diabetes, and chronic kidney disease, what you're seeing is that there's a high percentage in all of the age groups with these conditions. So these might be independent risk factors irrespective of age. All right. Okay. The last thing I wanted to sort of point out in this section on risk factors and severe disease and so forth is that in our population-based incidence study, and this is data just from Rochester, New York, we looked at how race and ethnicity might be impacting risk for hospitalization. And we found some really interesting findings. What we found was that in the very youngest age group, ages 25 to 44, you didn't really see, many cases to begin with. The incidence per 100,000 is fairly low, and really no differences necessarily between race and ethnicity, although you do see slightly higher race in Black and Hispanic adults. But when you look at this middle age group, I think that's where you're really seeing some separation. For the Black and African American adults, it's 3 times the incidence that you're seeing in white adults. When you move to older age groups, 65 years and older, you're actually seeing that gap close. And so if you were to design a vaccine or develop a vaccine and you have risk factors independent of age and you're only focusing on age for your recommendations, you might actually miss a significant group and be disadvantaging younger adults in certain minority groups who have a higher risk for hospitalization. Now, we don't think that this is being driven by their race or their ethnicity. We think it's likely being driven by the presence of underlying comorbid conditions in certain ethnic and racial groups at younger ages. And there's also probably socioeconomic and healthcare disparities that are driving some of this too. But I think it's really interesting data that again highlights that the risks that are important for severe disease with RSV are not just age. They do have to take into consideration things like underlying health. And then lastly, some recent data looking at annual RSV hospitalization rates by socioeconomic status. And you're seeing something very similar, which is that in lower income levels, you do see higher rates of RSV-associated hospitalization in any age group. And again, largely probably being just driven by things to like access to healthcare, as well as the presence of underlying chronic comorbid conditions. So take-home points, RSV is associated with substantial morbidity and mortality in older adults. Advancing age is our best known risk factor and does increase susceptibility and mortality to RSV-associated pneumonia. But there are other independent comorbidities, as well as for adults living in long-term care facilities that do increase risk of hospitalization among older adults and really adults of all ages. And then we have seen higher rates of RSV-associated hospitalizations in certain historically marginalized racial and ethnic, as well as lower socioeconomic status groups. That's probably being driven largely by the presence of these comorbid conditions, as well as access to healthcare.
Thank you very much to Dr. Branche, and thank you to our listeners for joining in. To hear more episodes from this session on RSV vaccination for older adults, see the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.